Hello, good afternoon. It's 12:30. It's July the 13th. Welcome to the first episode of RMC PEP. Somebody came up with this term, Physician Education Program. I know you had been sick and tired of us talking about community update on COVID, and understandably so, because it's 2 years. So we came up with a kind of brilliant idea to lure you back in, and we came up with a different term, PEP, but it's essentially the same thing. It's community update. So today I'm gonna be specifically talking about the outpatient management of COVID. We still have COVID patients in-house, but just for brief housekeeping, this is being recorded for future use. We also have recording here. We will post it on our RMC intranet website. And also, for those people who might have some questions, please reserve your questions later on. This is probably going to be like 10, 15, maybe 20 minutes. I'll be talking specifically about outpatient management of COVID. So let me just do a community update on our local numbers. So far today, July the 13th, we have 10 COVID patients in-house. Unfortunately, we had to open our COVID ward for the past, for maybe 1.5, almost 2 months, it had been open. But before that, we had a 7-week span that the COVID ward was closed. And they started trickling in. So we have 10 patients right now. We had 18 or 19 Friday. We were able to discharge some of them, fortunately. Of those 10 patients, 2 of them are needing ICU type of care. One is on the vent. So nothing really has changed as far as management is concerned in-house, but there's a lot of things that have changed as far as management in outpatient setting. So let me dial in with that. My society, Infectious Disease Society of America, which I have been a member of since early 2000, came up with a COVID-19 outpatient treatment guidelines plan. For those who got the email from medical staff office yesterday, that email has 2 attachments. One of them is a roadmap from IDSA, or Infectious Disease Society, which pretty much navigates if you have a patient as an outpatient. They're sick, but they're not really sick to warrant hospital stay or ER visit. There's a brief questionnaire there, and there's a kind of a pathway where to go, which drug to use, and things like that. It's a very useful, it's kind of basic pathway, but it's a very, very basic pathway. But we have come up, Kristen Pilgrim from RMC Marketing came up with another guideline. We actually got it from CDC, and there's another attachment there on that email which says RMC Physician Education. I'm going to show that on the camera, but essentially it really simplifies it to 1, 2, 3, 4 steps. That really will tell you what to do as far as your patients presenting to your office, either primary care, urgent care, clinic, and whatnot. So number 1 is if the patient tests positive for COVID, but the patient does not need hospitalization, so what do you need to do? Or the patient does not need supplemental O2, or they're getting oxygen chronically, but their demands have not changed. So what do you need to do? Number 1 is all patients should be offered symptomatic management, including pain relievers, either NSAIDs, aspirin, Tylenol, fever-reducing agents, the same thing, or other over-the-counter cold medications, Sudafed and all those things. Over-the-counter stuff, most primary care providers are very good with it, with what kind of brand, what medicines, what supplements to take, and things like that. For patients who are at risk for progressing to severe COVID-19, and what are those people? So on the other pathway, on the IDSA, or Infectious Disease Society of America pathway, and even on this RMC pathway that we have at the very bottom of the right-hand side, it lists the risk factors. So if you're 65 and above, if your BMI is above 25. So BMI actually is a body mass index, which kind of measures your height in inches and your weight in either kilograms or pounds. So normal is between 20 to 25, 25 and above, you're considered overweight, 30 and above, obese, clinically obese. So as a comparison, so if your BMI is above 25, you are at risk for severe COVID, progression to severe COVID, or hospitalization. As a comparison, everybody here has seen me. I'm 5'9", so that's 69 inches. I'm about 160 pounds. My BMI is 23.6. So I'm not 25 and above, but if your BMI is above 25, which pretty much a lot of people kind of fall under that. So you're at risk for severe COVID. So that means to say that, most of the medications that I'm going to be talking about in the next 10, 15 minutes, most people with BMI above 25 will be eligible for these medicines. If you have smoked or still currently smoking, you have cancer or a history of cancer, pregnant. Pregnancy is a risk factor. If you have chronic lung disease, heart disease, if you have a neurologic conditions, previous stroke, if you have a medical condition where you're dependent on some kind of device like a trach or a peg, Down syndrome, HIV, you are at risk for progression to severe illness and or hospitalization and or death. So that means you might be eligible for these two preferred therapies. So on that, I'm showing the pathway from RMC. The preferred therapies are two. Number one is the Paxlovid. Everybody has heard that. So for those who might not have heard about Paxlovid, Paxlovid is a protease inhibitor that was given EUA, or emergency use authorization, by our FDA sometime in December the 22nd to be exact, of last year. And it's a boosted nirmatrelvir. It's boosted by ritonavir. It's a protease inhibitor that we use a lot in HIV. As you know, I'm an infectious disease specialist, so HIV is one of the disease states that I deal with. So we're very familiar with PIs, or protease inhibitors. The second drug is remdesivir as an outpatient. Remdesivir was given EUA a while back, sometime last year, but it was not given EUA for outpatient up until this year. It's a 3-day daily remdesivir treatment, but unfortunately, it's not currently available here in Calhoun County. We are not doing that here at RMC for a variety of reasons. Number one is supply, although I think it has gotten better now. Number two is really staffing. So that's really primarily the reason why we could not. We want to do it, but staffing is an issue. We have to have an RN because it's an IV medicine. And number three is location. So we're still looking for a place to give it, safely, and obviously safe for everybody, including patients and staff members. So there's a lot of moving parts with, having this remdesivir IV given in an outpatient setting. But we have been giving it in inpatient setting for a long time. As a matter of fact, RMC is one of the early hospitals that got IV remdesivir when it was still in clinical trials. Long, and it's almost feels like 20 years ago, but that was in 2020. And number three is alternative therapy. So we're talking about now medications that, if you cannot get Paxlovid and or remdesivir, So we're going to the second tier drug, which is the monoclonal antibody called bebtelovimab, or we call it BEBMAB. It's given intravenously, and the second oral drug is called molnupiravir. So those are 4 drugs that are now currently available for outpatient setting. So going back to the first 2 ones, the preferred therapy, let's talk about Paxlovid. Paxlovid is a protease inhibitor that was given EUA, as like I've said, in December, based on a trial called EPIC-HR. It involved about 2,200 patients. It showed that if you have taken Paxlovid, it's a 5-day course given twice a day. If you have taken that, your risk of progression to severe illness. So we're talking about progression again, to severe illness based on those risk factors that I talked about earlier, is reduced in about 88 to 89%. So if you take this medicine, your chances of going to the ER, going to be hospitalized, or ending up in ICU, or even dying is about 88, 89%. So that's actually pretty good. But the problem with Paxlovid, since it's boosted by a drug called ritonavir, which is a strong inducer of cytochrome P450 system in the liver, it might interact with a lot of medications. There's a good website I have here called Liverpool COVID-19 Drug Interaction website and Ontario COVID-19 Science Advisory Table. You go onto that website and you click on what patients you have, what medications your patients have. It will tell you there's about 32 medicines that could interact with Paxlovid, and there's about 18 that you could definitely not give it to, including amiodarone, rifampin, those ED medicines, or Viagra and all those things. You cannot give those to those patients. So you might have to give them the alternative therapy that I mentioned about, including BEBMAB and or molnupiravir. So this, the problem also with Paxlovid is there's some herbal medications that your patients might be taking over the counter, including, but not exclusive to St. John's wort. It's some kind of herbal medicine. A lot of people are taking it. Some people actually don't even mention that to their doctor that they're taking St. John's wort. But you might have to ask your patients about those things. There is a class called statins, which is a lipid-lowering agent class, including Lipitor, Crestor. We just tell our patients that you might want to hold off on that for at least 5 days because of drug-drug interaction. Some of the drugs you definitely cannot give it to, like I've said, amiodarone, phenobarbital, those seizure medicines. It's a long, long list. I was trying to memorize it last night, but I fell asleep. But just go to that website. It will give you what medicines to avoid. These medicines, it will tell you that avoid this Paxlovid because your patient is taking these medicines. So the question is, this was given EUA back in December, and we currently have a subvariant of Omicron called BA4, BA5. And that study was done pre-BA4, BA5, obviously. We think that it might still be useful for that, although we don't have scientific and clinical data. There's no currently available data that we could use, but we think it's still useful for that. As an aside, everybody knows about Delta. Delta variant ravaged us locally, statewide, and nationally, and even globally in summer of last year. Then Omicron came winter last year, especially December, January, February, the parental Omicron. But now the circulating Omicron subvariant is called BA4/BA5. The reason why they could not really differentiate is so close together. The lineage is so close together that if you send your patient specimen for genomic sequencing, they will just tell you BA4, BA5. They would not they're not going to be able to tell you it's BA4 specifically or BA5 specifically because they're so close together. So they're just going to label it BA4/BA5. Anyway, this Paxlovid, we think it's still useful for that. So it's relatively safe, other than having drug-drug interaction. The dosing is 300/100 milligrams twice a day. It comes in blister pack, so you take 2 of the 150 milligram nirmatrelvir and 1 of the 100 milligram ritonavir. You take it in the morning and you take it at night. You take it for the first 5 days. It's only good, it's only beneficial if it's given within 5 days of onset of symptoms. It's kind of akin to Tamiflu or oseltamivir with influenza, which is good the first 48 hours of onset of symptoms. So beyond 5 days with Paxlovid, it's not really beneficial anymore because, as we know, the first 5 days is, essentially COVID has 2 phases. One is replicative phase, which is, they're actively replicating the virus, which is day 1 to day 5, day 0 to day 5. And beyond day 5 or day 6, it's proliferative phase or inflammatory. Not proliferative, inflammatory phase. So it's just inflammation, not necessarily the virus replicating. So replicative phase, the first 5 days, and inflammatory phase, day 6 onwards. So we think it's good, especially given the first 5 days. It also might be safe, although we don't have exact clinical data in pregnancy. But ritonavir, we give that to HIV pregnant patients we have in a HIV setting. So we think it's also safe. But FDA is kind of vacillating. So they're not really giving a full stamp of approval for pregnancy. Or they're saying if the situation calls for it, the risk outweighs the benefits outweighs the risk, you could go ahead and give it. So that's the Paxlovid. The second one is remdesivir. I mentioned about remdesivir. It only comes in IV form. Remdesivir is a nucleoside analog. It specifically inhibits that enzyme called RDRP, RNA-dependent RNA polymerase. So it stops the viral replication right there. It's given IV. We have been giving it in inpatient setting, but we're trying to get set up for IV outpatient setting. We currently don't have that capability right now, but hopefully soon. But hopefully we don't have to. Hopefully this also peters out. But it's also relatively safe. We have good track record with it. So now we're going to alternative therapy. The first pill on alternative therapy is called molnupiravir. It's a prodrug of NHC. It stands for N-hydroxycytidine, which actually, when the virus gets that, it produces what they call viral mutagenesis. So they have some kind of mutation in the virus level. So it produces a mutant offspring, and therefore they subsequently die. There is a theoretical risk that it might be absorbed into the human DNA, and therefore it might cause fetal malformation, but it has not been shown to do that. There's no report of deformed babies, after taking molnupiravir. There are 2 studies done on rats. One showed no deformed rats were born after molnupiravir. The second study had really questionable results, but they're thinking that there's nothing there as well. So FDA said you cannot really give it in pregnancy. So that's the only contraindication with this drug. So this drug was actually given FDA EUA as well in December. Actually, as a matter of fact, the day after Paxlovid was given EUA, December 23rd. And that EUA was given based on this trial called MOVE Out, MOVE, molnupiravir virus something out. and it involved 1,200 patients. And based on that clinical trial, your chances of progression is only 30%. So compared to 89%. So 89% reduction with Paxlovid, this is 30% reduction of risk to progression to severe illness. So there's a big difference between Paxlovid and molnupiravir, but these are the only two oral drugs that we have, so we'll take it. Again, relatively safe other than the pregnancy that I talked about. If you are going to give it to a woman on childbearing potential, you have to caution them about getting pregnant, use some kind of protection or something like that. Or if they have taken it and they're breastfeeding, you might have to caution that they cannot breastfeed for at least 4 days after stopping the molnupiravir. That's based on their FDA website. I could not really find the clinical trial alluding to that. Also, if you are a male and you're planning to have a baby, get somebody pregnant, you have to not get somebody pregnant for 6 weeks because it might stay in the semen for that long. I just found that out last night. But anyway, so that's molnupiravir, and the dosing is 800 milligrams twice a day for 5 days. Again, like Paxlovid, it's beneficial to be given the first 5 days, beyond which, what is it called, the phase? It's not replicative phase anymore. It's inflammatory phase. So it's not good anymore because you're trying to kill the virus. So it's only given the first 5 days. Lastly is the monoclonal. Everybody knows about the monoclonal. We've had, I think this is the 4th or the 5th monoclonals that we have. It seems that every variant is different monoclonal because most of the monoclonals that we have is not pan-variant or pan-genotypic. So it depends on what kind of variant you have. This new monoclonal called bebtelovimab. I have to kind of slow it down. So we call it bebmab. It's a humanized monoclonal specifically for the spike glycoprotein. And it's specifically active against the Omicron variant. Again, it was given EUA during the parental Omicron, the BA1, BA2. Not really, we don't really have much data on BA4, BA5, but we think that it's also beneficial for these patients to get it because it has activity against it as well. It's given intravenously, so it's only given in a setting wherein they have nurses and they have a way of monitoring them about an hour after the infusion. It's about an hour infusion, and they have to have somebody there to check if they get some kind of reaction, even mild to, heaven forbid, anaphylactic reaction. It's definitely safe for pregnancy because we have given it a lot to pregnant patients. Potential side effects might be, infusion site reaction, a little bit of headache like any monoclonals. But other than that, those are the 4 medication therapies now that are currently available for outpatient setting. Those 4 medicines do not substitute vaccination. So we're going to go back to the ones we talk about over and over again, WWWV. So I know people are sick and tired of wearing their masks. I am, but we still have to wear a mask. People are sick and tired of social distancing. You still have to watch your distance. People are sick and tired of washing their hands. I know. But do we have the capacity now to hopefully mitigate this and slow down this spike again by vaccinating? Although we've had some patients who have been fully vaccinated, the primary series of 2 plus booster, either the first booster or the second booster, still got it. But in general, statistically speaking, if you have been fully vaccinated, fully boosted times 2, your chances of ending up in the hospital, ICU, or dying are much, much lower compared to if you're not vaccinated or you're not boosted. Please do avail yourself if you're eligible for the vaccine and or the booster. With that in mind, I think I pretty much covered whatever you need to do in the outpatient setting. Thank you for listening. We now open the floor for questions and or comments. Thank you.
This is Jim Yates. Two things. One, when we tried to prescribe the Paxlovid to the local drugstores, they will not give them 10 tablets. They come in those packs, and they give them the whole pack. They will not give them 10 tablets. They will give them the whole pack. They will not break it out into 10 tablets. And the second is your opinion about the delayed, the reports on Paxlovid getting delayed when you come off it and symptoms coming back.
Yes, good questions, Dr. Yates. So the first question about the blister pack, yeah, unfortunately, I think that's the only way that they're manufacturing, as far as I know. It has specific instructions. I think it's kind of color-coded as well. The morning dose is kind of darker, and the evening dose is lighter. It might be, and I feel your pain about having those blister pack, because if your patient has an EGFR of below 50 or below 40, you have to cut back on the dose. So instead of having them take 150 milligram of the nirmatrelvir, they only have to take 150 milligram tablet plus the ritonavir, which is 100 milligrams. So it might be a little bit cumbersome, especially for people who might have problems with their vision, so they can't really see, is it dark, is it light? They don't know, the blister, or they might have problems with, hand arthritis, because you have to open the blister pack. So it's a concern, and hopefully, Pfizer, the company that manufactures it and distributes it, knows that. I think they know that already, and hopefully they'll come up with some better way of packaging it. I don't know if that really completely answers your question number one. Question number two is the delayed or rebound COVID after Paxlovid, and it's a known entity. That study was published about 4 or 5 weeks ago, and there's some case reports of patients having recurrence of their symptoms, whatever the symptoms are, and or having their swab come back positive again, to the point that the swab might have, this is like an RNA PCR swab, so they have increased viral load after having taken their Paxlovid for 5 days. So they call it rebound. The exact pathogenesis, the epidemiology, I was looking on this about 2 days ago, because somebody asked me this exact question about this rebound. They don't know yet. Those are case reports. So I have not personally seen it. I know it happens. They're going to come up hopefully in the next several weeks about the exact pathogenesis, which people are these, epidemiology and all those things. The only thing that I was able to find out online about what to do is you don't have to retreat them with another round of Paxlovid, but they have to go back on quarantine or isolation. So they have to, because they're still shedding. So they are still shedding, therefore they're still infectious, so they might have to go back to isolation. But other than that, there's not a whole lot that you could do.
Your patients in holy.
Say it again.
So in other words, appears that this rebound phenomenon is very infrequent, which is a good thing.
Yeah, I know. It happens. It's not just you. It's actually, there's a report on that. There's an article that came out, I think, about 5 weeks ago. Thank you. Any other questions?
Comment. I thought that, I heard that the rebound was only like 2%, and the other thing is that it's
Your call
a part of the national.
We appreciate your patience while moving. Our receptionist will be right with you.
Yeah, you're breaking out. I heard about 2% on the rebound. I think you might be right on that that number. I briefly glanced on that article, but I think you might be right about 2%, maybe higher. I guess it's not 2% for Dr. Yates because he experienced it.
We appreciate the patience in holding.
And the first question, I did not quite get it. And
all right, I'll try again. There's convalescent plasma on your documentation.
Yep. So on the IDSA website, I'm sorry, I was only able to discuss all four. I did not discuss the convalescent plasma. IDSA on their pathway has convalescent plasma, which we stopped giving about a year ago, maybe longer than that. The problem with convalescent plasma, in general, the idea is great. So you get somebody's plasma, somebody who has recovered, get their plasma, and hopefully that they have a lot of immunoglobulins. The problem is it's not standardized. You really need not just binding antibodies, you need neutralizing antibodies. And so far, the commercially available convalescent plasma only checks for binding antibodies. Yeah, it's great, it binds, but what you really want is the neutralizing antibodies. Those are the ones that kill them, not the ones that bind them. So the most of the commercially available ones only check for binding antibodies. So that's why we're not really a lot of societies, except IDSA, they're not really hard on promoting convalescent plasma. We gave it a lot as an outpatient setting, but we have not given it in outpatient setting. And we are not intending to in the near foreseeable future. It's just not in the works for us.
Okay, so it's still...
I skipped that.
All right, so the way we're doing it here is sometimes inpatient, and you're still just... And most of the other societies aren't pushing it. IDSA is still doing it. And
yes.
Because you can't get a good... the quality is not, consistent.
Correct. That's exactly the reasoning.
Okay.
Yeah.
Okay. That's it. That's it for me.
All right. Sorry about the fiasco on the thing, but I think they stopped already. Any other questions? Hopefully we'll do this again, or hopefully not, because we had a big spike last week. We got really busy last week. We slowed down some this weekend, but it's just up and down. But it's not really gonna be the same level that we had back in the Delta wave in the summer when we had 90-something patients in-house. We currently have, like I've said, 10 patients. Have been very efficient in the staff. I know there's a lot of confusion and frustration about staffing shortage. The currently available staff that we have, the ones working here, I cannot really thank them enough about the hard work that they're doing. It's just that they're overworked, and imagine having to work 5 times, 7 times than when we had Delta wave last year. It was just too much. It felt like 10 years ago, but it's just too much last year. But we have capability of getting that much if that scenario arises again. We have 1 COVID unit open. The other one is on standby. But we're having problems with staffing. But we cannot thank enough the staff that we have right now, and we really appreciate them.
Before you go,
yes, go ahead.
All right. Even in this last wave, I have yet to really admit many people with actual pneumonitis. And I was wondering, you said that you did have some people that have been boosted and that have been boosted and still come in. Have they been coming in for pneumonitis, or have they been coming in for other stuff?
Yeah, so that one patient
Like for
yeah, that patient that I was telling you about, he, she, they were, they had their primary series of 2 vaccines, Moderna. They had 2 boosters, Pfizer and Moderna. They were actually given 1 dose of monoclonal antibody, the Bevmab, a week prior to them coming in. So they came in hypoxic. We had to give them high flow O2. They are now outside the COVID ward. We got them out after 2 negative COVID testing. So they're better now. I'm still waiting. That's the one that I sent for genomic sequencing, because they were vaccinated ×4. They got monoclonal antibody, and they still got sick. They progressed. Although they have risk factors, they were older. They have COPD and a little bit on the heavy side. But I'm still waiting for the genomic sequencing, which, as you know, we don't do in-house. We send it out to Tennessee.
Right. Okay. So far you've had 1.
I have 1. Yes. Personally, I know of 1 that fully boosted, fully vaccinated, and even had monoclonal antibodies, still got sick. But they are better now. They're in the ward somewhere, medical ward, non-COVID ward.
Well,
we got them out Sunday.
I mean, that's not bad. That's not bad considering the amount of transmission we have right now.
Thank you. Yeah.
I appreciate it. I mean,
thank you. Yeah.
I mean, compared to the previous waves, right?
Yeah, I gave her the whole
all I
shebang.
want.
Yeah. I was not gonna let them die on me. So they're better now. All right, thank you for that comment. All right, we'll do this again sometime. Please get your comments or questions, and we'll get somebody to talk again. Thank you. Bye.